So the best data we have for baseline biomarkers is in the AML study with Azacitidine Nivolumab. What we saw is that actually in all the patients who responded, they had a higher T cell infiltrated baseline. And also when we looked at the subtype of T cells, because all T cells are not equal, we saw that the patients who had more CD4 effector or more CD8 to Treg ratio, which is a favorable immune profile usually associated with a good anti-tumor outcome, were the ones who responded much better, as opposed to those who had either few total T cells or had T cells but did not have a favorable ratio of CD8 to Tregs, they did not respond. So this has been shown in lung cancer, kidney cancer, bladder cancer, that patients who already have a favorable T cell infiltrate in the tumor tissue are much more prone to respond to manipulation, because you only have to activate the T cells. You do not need to bring in T cells plus activate them. And that's what we saw. And so this could be a very useful biomarker. We're also looking at other biomarkers such as PD-1, PD-L1, CTLA-4 at baseline. We did not see a clear correlation between T cell PD-1 expression and response, but we did see, if you look at the ratio of CD8 T cells that have PD-1 to the Tregs that have PD-1, meaning you have more activated T cells that have a PD-1, we did see that that actually significantly corresponded to developing a response. So we think that in the next few years, 1.5 years, as these studies mature, go into larger multi-center studies, we're going to be having a very similar scenario to solid tumors, where we will have 30-35% patients who respond. When they respond, they have a very nice benefit, and it's durable, which is really the main key point of these drugs, is the durability. And hopefully we will be able to select them by building into flow panels simple markers such as CD3, CD8, CD4, FOXP3. And some of our upcoming studies, we're going to be studying this in more detail.